السلام عليكم.
وعليكم السلام. هلا دكتور.
هلا ابراهيم.
يا هلا وسهلا دكتور. مساء
معليش،
الخير.
قال لي عند راسي هذه من المؤتمر. أنا في جدة في مؤتمر القسطرة، وحاطين لهم مع الأصوات. يبغون نبدأ الساعة 8:30، باقي 3 دقائق.
اوكي. If you can share your screen دكتور، إذا كان في سلايد.
يا ريت.
هي الآن في شير سكرينينج.
طبعا يا إبراهيم، الاختبار، أنتم كلكم كارديولوجي فيلو، ما في انترفنشنال فيلو، صح؟
يا جنرال فلو.
إيه. عادة الرسوب والنجاح ترى في الكورونريز. structural هذه something advanced، عشان هذه رغبتكم في الستراكشرال. Among the structural, the most common is TAVI. Though you need to know, of course, valvular heart disease, you need to know aortic stenosis, the pathology, the incidence, the clinical manifestation of aortic stenosis, an exam parvus tardus, an exam the related to the aortic stenosis, and correlate if there is a combined aortic regurgitation at the same time, and aortic cardial على هل يصير في paradoxical splitting of S2 ولا لا. Galivarden phenomenon. What is Galivarden phenomenon? And the JVB, what happened is, is it affected by aortic stenosis by itself or not? Um, Other extracardiac manifestation of aortic stenosis, which is the poor cardiac output elsewhere. يعني مثلا لما يكون عنده carotid stenosis, you will not know, and even if they did carotid ultrasound, they will not be poor, but poor flow that make things more inadequately diagnose other diseases elsewhere. حتى coronary disease نعمل بعد عادة FFR or IFR وكذا. In aortic stenosis change, everything changed because there is inflow disease to all of these territories. Investigation wise, echo, what are findings in the echo bicuspid or غيره. إذا كان bicuspid, you look for coarctation. يعني هذه الأشياء بعدين got all of these right. يعني all of these right, then we can move on to TAVI. لكن as you mentioned, there is a session of TAVI last year. We have to respect that. Then you have to follow. Okay, so now it's 8:31, so we need to start. You ready?
Yes دكتور.
So after this introduction, you know what you need to know. I would like things in the procedure itself, لكن all the science behind the procedure and the complication after that you should know as a cardiologist. I am not in the scientific writing committee of the board exam, but I am an examiner. Increasing demand of aortic stenosis. There is a constant increase in the life expectancy في السعودية or elsewhere, and this increased number of patients, this will reflect to increase of degenerative aortic stenosis, and the prevalence of aortic stenosis is 5% in people aged more than 85 years of age in the West. But in general, if someone has aortic stenosis, symptomatic, we offer aortic valve replacement. But to be honest, there is almost half of the patients need one of the high risk for surgery or the patient afraid of complications. The risk of stroke is 2%, but I think it's that more than 2%. I mean, 2% is we quote 2%, but usually it's 2.5% or something like that. And let's say what the guidelines said. We will have Saudi guidelines, not yet published. But let's say what are the international guidelines said in the TAVI. There is the similarities in guidelines, American and European guidelines, but there are few things are differ between American and European. I would like to summarize them in the coming 5 slides. In asymptomatic aortic low, the C guidelines use LVEF threshold of less than 55% in the absence of other evident cause. So they recommend to go with the TAVI. And the ACC, they mentioned LVEF less than 60% in the setting of progressively decreasing AF on 3 serial echocardiograms. So echo is 55, the other echo is 57, and the third echo is 55. This is not, yes, they are less than 60%, لكن they are not decreasing. It has to be 3 serial based in the ACC guidelines. طيب, there is a very common question. You need to focus on this. When to use tissue, when to use mechanical surgical aortic valve. Now we're talking about aortic valve. The reason behind this, because when we compare TAVI to surgical valve, we compare them with the bioprosthetic valve. But if it is the mechanical valve, no, this is different. Mechanical valve durability is high. And the problem with the mechanical valve is the anticoagulation. So it's after in the term of tissue and mechanical, patients should be shared this discussion, and also take in consideration the risk of bleeding, the risk of anticoagulation as our patients. يعني مثلا واحد he's living in a rural area, so I'm not sure whether he will take warfarin ولا لا. So this patient, I will avoid mechanical valve, even if he is young, because I don't trust him to take warfarin and get the usual, the regular treatment. Okay, let's say we discuss this. We have the patients and the anticoagulation, no problem with it. So when I use tissue, when I use mechanical valve, ACC and AHA, it depends on the age. ACC, they say if less than 50 for mechanical, more than 60 is the tissue. Why? Because the average 25 life expectancy may be higher, but the average life of the tissue valve is 10 years. So more than 65, go with the tissue valve. Less than 50, go with the mechanical valve. Between 50 and 65, this is the gray area. But the European use different threshold. They said less than 60, use mechanical. 65, use tissue. Both of them agree more than 65 use tissue, but mechanical, there is a difference. Okay, so this is tissue and mechanical. What about the TAVI versus SAVR, which is the tissue of SAVR, surgical valve? Age threshold, come on. Both guidelines highlight patient age as a major consideration surgical valve versus, يعني we have discussed that before. لكن ACC guidelines use age threshold of less than 65 or life expectancy more than 20 years to recommend TAVR, and age more than 80, life expectancy less than 10 years to recommend TAVR. So TAVI to elderly in the American, more than 80. But the European is شوية loose. They said the more than 75 go with TAVI. Saudi, I think we are going with that, with the more than 75. If you got this question in your exam, when you use the TAVR, you use it in age more than 75 out of question. Less than 75, discuss. More than 75, لا تفكر. خلاص, TAVR. Don't think about surgery. Heart team and risk assessment. Both guidelines, American and European, agreed on that. Both guidelines stress the importance of heart team and clinical decision. And when you use heart team, we use STS score and predicted risk of mortality calculator. هذه the clinical preferences, reality, and utility for the assessment of surgical risk. And for symptomatic high gradient aortic stenosis, this is out of question. Everyone would say go for intervention. The problem with the low flow, low gradient aortic stenosis, this line is very important for clinical decision. And this is a common question in exam. What to do in a patient with low flow, low gradient aortic stenosis? Both guidelines recommend the bitumen stress echo to distinguish true severe aortic stenosis from pseudo-severe aortic stenosis in the setting of low flow gradient aortic stenosis with reduced ejection fraction. The European recommend intervention in the absence of contractile reserve. حتى لو ما كان فيه contractile reserve, the European recommend to do intervention if the calcium score confirmed that the aortic stenosis is severe. Calcium score, it's different from coronary score. This is the aortic valve calcium score. In general, in women, if it is more than the 1300, men more than 1000 is severe. The ACC/AHA guidelines primarily recommend surgical aortic valve for low flow, low gradient aortic stenosis with reduced ejection fraction. بينما the AAC guidelines imply that TAVR can be used among these patients. Why is that? Because the American depends on partner trial. In case of normal LVAF and patient has low gradient aortic stenosis, the ACC guidelines recommend intervention using an integrated approach that includes CT, cardiac CT, and the ACC/AHA guidelines recommend intervention if aortic stenosis is felt to be the most likely cause of normal EF and the patient has low flow, low gradient aortic stenosis, we can go with TAVR. If a patient is symptomatic, they have to be symptomatic. And a patient who is asymptomatic, both guidelines recommend exercise testing. It used to be is 2B recommendation, but we all the time do that. In our community, those patients, the old people, they cannot exercise. They have knee issues. They have other diseases that affect their ability to walk. But if this is the case, we can say adverse prognosticator, including we see the Vmax more than 5 meters per second. That means the gradient is 60 and more. So severe patients will benefit from the aortic valve replacement, whether it's TAVR or surgical, or elevated beta natriuretic peptide. However, in addition with normal flow, low gradient, aortic stenosis, and they are asymptomatic, both guidelines recommend follow-up rather than intervention. Very important, bicuspid aortic valve. All the clinical trials, they excluded bicuspid aortic valve. Though the first case of TAVR was done to patients who has bicuspid aortic valve. We do bicuspid aortic valve in a daily basis everywhere. However, in the guidelines, if you see bicuspid aortic valve, prefer surgery for surgery. ACCHA recommends TAVR, but no formal recommendation, but note that the TAVR is more appropriate in the setting of bicuspid aortic valve and those associated with aortopathy. But they didn't mention anything else. In Saudi guidelines اللي ما طلعت الى الان وما راح اكيد ما راح تسالون عنها, they recommend TAVR in a patient who has no aortopathy. Aortopathy قصدي aortic aneurysm. The last thing for the guidelines between the American and European, the non-transfemoral TAVR. Whenever we say TAVI, we mean femoral. Whenever we are outside the femoral, so those they have limited role, and the evidence is scarce, and we should say this should be as a last. So let's now talk about what are the evidence of TAVR. TAVR started with the extreme risk people, with the partner 1B. They randomized patients 1-to-1 TAVR versus standard treatment in 358 patients. Those patients are not eligible for surgery. They have prohibitive risk. This is where the TAVI start balloon. Then high-risk patients, this is partner 1A, randomized patients TAVR versus surgical, and they are high risk, but not extreme, 609 patients. And then they move to intermediate risk patients, and they randomized patients 1-to-1 TAVR versus surgical, and the number of patients increases, 32 patients. Finally, low-risk patients. In a low-risk patient, this is partner 3, randomized 1-to-1 TAVR versus surgery, about 1,000 patients. All of these trials are published in the New England Journal of Medicine, and all of them showed TAVR is not inferior to surgery, and this one showed very effective to use TAVR with very low number. One of the few medicines available in this era of medicine that saves life to that degree. It reminds us about the penicillin in case of meningitis. So it's a huge benefit of those patients, saving small number of lives. And they consider partner trials one of the top 5 clinical trial in medicine, 1,000. They collected all the clinical trials. What are the best 5? One of them is the partner trial. Not only that, it has a durability, 5-year outcome. Those 3 trials, the equivalent result to the surgery. So it is durable by 5 years. But what about partner 3? If I want to ask anyone about anything related to TAVR and clinical trial, I will ask about partner 3 because it's relatively new trial and they have for the 5-year outcome. So partner 3 is symptomatic severe aortic stenosis, risk assessed by TS score less than 4%. And they are randomized 1-to-1, 1,000 patients, surgery versus TAVR, and the TAVR balloon expandable. They follow patients 30 days, 6 months, and annually through 10 years. They have the 5-year outcome until now. And if you see the baseline characteristics, those are high-risk patients. So 73%, half of the patients in both groups, or they are in the 60s, most of them. Male, the majority are male, BMI are okay, and the HA score is 1.9. So it's low risk. And they have the advanced symptoms in third of patients. So this kind of patient, the baseline characteristic. And whenever you read a clinical trial, please, and when you read them, take in consideration characteristics. Sometimes say stroke is different from one trial to trial, and the reason is the baseline characteristics. So it can be not only the mode of therapy they are testing, but also you need to see who are the patients and you need to see who are the operator. Very important. And how to see who are the operator is to compare that study to similar previous study. For example, this partner 3, which is called Evolute Low-Risk Patients Clinical Trial. So Evolute low-risk clinical trial is the low-risk population requiring TAVI using Evolute R, Medtronic. But this one is Edward valve, balloon expandable valve. So 5-year outcome showed it's not inferior. Death, stroke, or if you first 12 months, actually the TAVI is superior to surgery. Surgery outcomes 15.6% die or had stroke or rehospitalized, and the TAVI 8.5%. When you dissect them all, let's say in death from any cause, a death from any cause, surgery is 1.1%. At 12 months is 2. And here at 12 months, stroke is 3.1%. This is a lot to have a stroke here, 3.1%. But in surgery, in TAVR is 1.2%. And here in the rehospitalization is 11 versus 7.3%. So if you combine all of them, TAVR is inferior trial, but it's, as you see, it's clearly TAVR is superior to surgery. And the other trial, transcatheter aortic valve replacement, expanded valve in a low-risk patients. You see the age of these patients. So here, as treatment analysis means patients who are enrolled to TAVR and underwent TAVR, compared to patients enrolled to surgery and underwent. As you see here, 725, and here 678. And here, intention to treat, the patient who the randomized to TAVR and whatever he take. Maybe he's not taking a TAVR. That's why it is more patient here, 734. So not, this is 725. This is as treated. This is for sure all of them got TAVR. Here, there might not be got TAVR, intention to treat. And surgery, 734, and 678, they did surgery only. So, but they put them line by line because when you do statistics, you need to randomize patients taking consideration of all the bias. Here, you are super patient, and those who are excluded, there might be very sick, or they have problem with the femoral artery and they got perforation. That's why they underwent surgery. That's why they excluded. But here they include them, even if they got surgery, but they are enrolled to TAVR. They should stay in TAVR. This is TAVR arm surgery. This is clear to everyone. Anyway, so the reason why I'm showing this to see that the baseline characteristics is 74. So half of the patients less than 74, and in both groups, and this is almost the same as the partner 3 trial. And the 25% they have severe symptoms. STS score 1.9, 1.9, almost the same as the. So for patient population, I can compare partner 3 with the Evolute low risk clinical trial based on patients only. Okay, endpoint by 24 months, TAVR is way better than surgery. You dissect them down. Let's say death from any cause or disabling stroke is 0.8 in TAVR and 2.6. This is huge. At 30 days, 2.6%, they either die or they have disabling stroke. This is huge. And 2.9 TAVR, 4.6 in surgery. This is also huge. If you remember, when we did the analysis for the partner 3, these are not the number. Look at the surgery. Surgery arm is 4.6, death or disabling stroke. 3% die in surgery, 12 months. When you go to partner 3, here, death from any cause is 2.5 at 12 months and 1% at 12 months, and versus surgery, the TAVR. So focus on 2.5. Here is 2.5%, and here is 4.6%. They have the same patient population, them less than 63. This gives you, as a reader, that the surgeons in this clinical trial are different from the surgeons with the partner 3 trial. So we cannot compare Evolute R and the Edward valve. We can't, because the deaths are different in those patients. Here, 3% at 12 months. And there is 2.5%. This, and death, when you say death, there's only one definition for death, either alive or died. But stroke, patient might have the weakness in the patient might have patient may have complete hemiplegia in the left arm and he's in a wheelchair. So definition of stroke is different here, but the death is one definition. So when you compare something hard, compare it with death. Here we got 2.5% at 12 months, and here we got 3% at 12 months. So we get ask you the low risk patients. There are 2 trials, partner 3 trial done, and the low risk clinical trial. Both of them showed TAVR is not inferior to cervical aortic valve. This is all what you should say in exam related to these clinical trials. Give you an example case. 77-year-old gentleman is known to have mild cognitive dysfunction, complaining of dyspnea and exertion, and sometimes deny symptoms. Those are elderly people. They have Alzheimer, they have all sorts of things. So this patient denied symptoms one time, then we did CT scan, and the CT scan cardiac CT score, calcium score of the valve is 4,600. And as I told you, more than 2,000 is severe. Echo showed calcified trileaflet aortic valve stenosis with mean gradient of 50. The higher the gradient, the more likely the benefit. If a patient has 41, 42 mean gradient, I will wait. I will wait because that's severe enough. And the patient is symptoms is not sure. But when you go to 50, 60, there is mortality benefit. There is a mortality benefit in those patients when you do aortic valve replacement. Not do when we do echo is the aortic annulus diameter and LVOT. When the LVOT is small, this can push the valve up and dislodge the valve. This can compress the conduction system. And the conduction system usually is located in the membranous septum. And the membranous septum is very between 5 millimeter up to 50 millimeter. The longer the membranous system is, the better. And this is the important thing that we need to watch. Sometimes aortic annulus, if it is huge or very small, we cannot do it because we will do harm when we do TAVI. That's why we have to measure aortic annulus. And the other thing, the sinus of Valsalva, we have to measure it. It has to see more than 8, because when we put the valve, we have a space. We should have a space for the blood flow to go around the valve to get to coronaries. But if it is very narrow, that's very problematic. So you have to have the sinus of Valsalva measurement, aortic annulus measurement, and LVOT measurement. And this patient has mitral get worse when patient has aortic stenosis because the LV systolic pressure is huge in order to overcome aortic obstruction. So this, a lot of pressure can make aortic stenosis worse, aortic mitral regurgitation worse. When we fix the valve, the mitral regurgitation will get better. So it is not a contraindication to do aortic replacement or TAVI mitral regurgitation. But if it is severe, it depends. Is this primary mitral regurgitation or secondary mitral regurgitation? Primary mitral regurgitation means there is a problem in the mitral valve. The rheumatic mitral valve, the sclerotic mitral valve, the allotmac in mitral valve endocarditis. So there is a problem in mitral valve. Mitral regurgitation means there is a problem in the ventricle, and that's why it's dilated, and that's why it's getting regurgitation, or because of what I mentioned, the increased systolic pressure. And here the gradient, how they calculate it. So tracing the pressure, and if a patient has aortic atrial fibrillation, you need to have readings and by 5. So it's get the average. And the cutoff for mean gradient is 40 for severe. So this is how TAVI looks like. This is Evolutar. And here is the annulus. And here is the sinus of Valsalva. And here is the coronary height. And here is the height of sinus of Valsalva. So the blood flow comes from here, going to the right, and come from here, going to the left. And this is how it looks like at the end. We can see the coronaries, the left coronary, and the right, and the valve here. And the valve anchored at the level of the annulus. And if there is calcification and mitral, usually, so The leaflet, the new leaflet here, it's up. It's called supraannular. The leaflet usually attached as the annulus, but here the leaflet is here. Supraannular leaflet. Complication. Look at the aortic valve. Blood flow comes here. Here can cause perforation, can the heart annular rupture, and can cause conduction disease. Here can cause aortic regurgitation. We'll mention all of them right now. Here what they can show to you. Patient has our TAVI, and all of a sudden this happens. This is his blood pressure, and now his blood pressure. There is hypotension, and when you see the ECG, there is clear. It's depression. Whenever you see ST depression, lead 1 and lead 2, those are not related leads. Lead 2 is inferior lead. Lead 1 is lateral lead. When you see findings here and here, that means there is something global affecting the anterior, lateral, and inferior, which means, and here the right is okay and the left is occluded. Left main stem compromised by thrombus or valve skirt or semi-occluded displacement. The most important thing to do is stabilize the patient by ECMO and get the flow as soon as possible. The other complication you need to know is a complete heart block. The incidence of complete heart block, it used to be valve, but now is single digits or 10%. And the reason, because there's a lot of improvement in techniques and in the balloon platform and the stent platform. There is something called conventional alignment. There is something called cusp overlap view. Then there is a lot of things that we are done that improve the incidence of complete heart block. And the thing that you need to know, what is the strongest factor for TAVR patient? The answer is right bundle branch block, because the patient may develop left bundle branch block because of the pressure of the balloon or the pressure of the frame of the stent, TAVR stent. This pressure causes left bundle branch block. And the sitting in the right bundle branch will help. As complication, they may show you this thing, and here you see the diastolic pressure here, and here the end diastolic left ventricular end diastolic pressure, and here the systemic diastolic blood pressure. And after the implantation, the blood pressure reduced, which is good, which means there is no aortic stenosis. But if you see here, diastolic blood pressure reduced, and the LV EDB increased a little bit, reaching up to more than 20. So that means there is aortic regurgitation. The most common cause is the paravalvular leak. Okay, causes of hypotension after TAVR. This is another question. Patient in the CCU underwent successful. First is bleeding. Look at the groin, maybe it's bleeding. Other complication, ventricular rupture, but this usually in the cath lab. Acute valve dysfunction, like one of the valve does not open well, or something happened to the valve, or coronary artery obstruction. Sometimes coronary artery obstruction does not happen during the cath, because especially with the coronary time. Once it is expanding, it's pushing things. When it's pushing things, there might be a thrombus formed in one of these areas, then cause coronary artery obstruction. Always do ECG, always. Always do echo. Always look at the groin. Think about all of these in around the. The other possibility, multiple rapid pacing episode in patient with poor LV function. If a patient has poor LV function, multiple time got rapid pacing, the heart is very sick. When you bombard the heart, demanding a lot of heartbeat, this can make the heart stunned, hypotensive, get worse. The LV function get worse, cardiac output get worse. Last thing is suicide. What do we mean by suicidal LV? In severe ventricular hypertrophy, if a patient has low volume because he's fasting for 18 hours as a preparation for this procedure, patient is fasting, the LV volume is low, there is not enough blood, and it's used to contract fast and hard to overcome the aortic. Then the stenosis is released. This left ventricle used to contract very hard. When it is contracting very hard, sometimes there's no blood in it. There's no blood. It squeezes all the blood inside the heart. Open and again squeezing, then it's like dying. There is no cardiac output. The best treatment for after removing obstruction, LV decompresses to such an extent that the subvalvular hypertrophy obstruct outflow, and the treatment is give fluid. Patient has pulmonary edema, don't give diuresis. Save the patient, give fluid. And sometimes, if a patient has left ventricular hypertrophy, before we do TAVI, we can do sometimes we do CRTD. This is just to play with the contraction, right and left, to make sure that reduce the possibility of this suicidal LV. But the one thing to remember, suicidal LV happens with severe LV dysfunction or HOCM patients, and the fluid treatment of choice at your level. Significant annular rupture, this is what we all afraid of, but with the self-expandable stent, it's less of a concern. Ventricular perforation treatment, pericardial, when you do echo, pericardial drainage, autotransfusion, conversion to open surgery. Device malposition or device embolization, this is we do in the lab. I don't think they're gonna ask you about this. Major ischemic stroke, minor ischemic stroke, or hemorrhagic stroke, always we have somebody, the surgical or neurointerventionist on board to, in case of stroke, to retrieve whatever is embolized. Atrial fibrillation can happen, treatment as usual, but it's one of the things that you need to mention. If they say, what are the complications of TAVR, is we said paravalvular leak, hypotension, the complete heart block is very important. Atrial fibrillation, you mentioned atrial fibrillation. Shock, low cardiac output, major bleeding, vascular complications, the treatment according to the cause. And believe it or not, this is what I think, and don't quote. I think number one cause of death after TAVI is vascular complication. Is not annular rupture, is not coronary occlusion, it's not complete heart block, not shock, it's not stroke, it's vascular bleeding, because we underestimate that issues in a patient with bigger problem in the heart. So we got the bigger problem, we forget about the vascular. So vascular issues is crucial. It can kill. I remember one of the cases in one of the best center in the kingdom, in Saudi Arabia, and the patient had excellent TAVI, patient 4 hours. reviewed him. I noticed that they used trauma wire. Whenever they use trauma wire is very slippery and it can perforate without noticing. And the pushing trauma wire without fluoro, it went to the renal artery and it perfed the renal artery. And the patient had retroperitoneal bleeding from the renal artery, and the patient died. Okay, so this is what I have, and I'm willing to receive your questions. Ibrahim.
اهلين دكتور، يعطيك العافيه، شكرا جزيلا. عندي سؤال دكتور. CT pre-TAVI assessment, what are the things that we have to يعني to assess or check before TAVI in the CT?
Yeah, so the same thing as I mentioned here. But the same thing as I mentioned here is the aortic annulus, LVOT diameter, surgical, the sinus of Valsalva diameter, and coronary height, and the ascending aorta, and also the whole track. Maybe the patient may have aortic occlusion, abdominal aortic occlusion. The patient may have the severe stenosis in the iliacs. They have to have the iliacs and arteries are more than 6 millimeter. And nowadays, portfolio used to be 24 French, then 18 French, now 14 French. One French is 3 millimeter. So 40, the 0.33 multiplied by 14, Saro, 0.33 multiplied by 14 French, 0.33 multiplied by 14, Sawi, 4.62. So you need to have the femoral and the iliacs more than 6 millimeter, because the sheath is 4.62, increase the 2 millimeter from one side to another side. So it's just to be easier to pass the valve. So these are the things you need to know. Do we need to know stent types, sizes, diameter, normal range in CT pre-assessment? I don't need to know the thing, the valve, the guidelines, and when to refer patient to TAVI, and what are the things that you need to watch after TAVI. But TAVI itself, I don't think that you need to know more than that. I don't think so. And there is a question here. And above 40 age. Of course, TAVI done in patients more than 65, more than 75 people, and whether to do coronary angio or not. If the CT scan normal, I don't need to do angio, but usually they are not normal because of calcification. They cannot see. We do baseline angio. Could slide please? Yeah, you can. Exam, we have to answer based on which guidelines. Now, there is no Saudi guidelines yet, but they are in press. For me, I will go with, as I mentioned to you, the European and America are the same, and just a severe aortic stenosis, patient more than 75 should go for TAVI. Yeah, by the way, the one that's TAVI, not surgery. TAVI and not surgery is patient with renal failure on dialysis. And the one case, there's surgery, not TAVI. Surgery, not TAVI, is patient with endocarditis. Endocarditis, you cannot put the prosthesis in septic or septic environment. So This one case of TAVI, no surgery option, and surgery no TAVI option scenarios that I know. This kindly show the slides. Okay, I think I have angio for CAD before PCI should be done before TAVI. Yes. So if a patient disease, did we do PCI first or TAVI first? It's controversial because patient might not be symptomatic because of the coronary disease. It's because of aortic stenosis. So because of controversial, I don't think nobody would blame you to take controversial. But my way, I always fix the coronaries. Is to get return to be asymptomatic. Then if a patient is asymptomatic, measure the gradient more and more. If it is more than 60 or 50, so very high gradient, very high gradient, then you'd say, yes, I will go for TAVI. If a patient is 41, 42, I fix the coronaries, and I'll say, you know, I will delay TAVI later on. Maybe in 6 months, we'll do echo and see. Let's push the valve implantation more away because it has a durability. It has 10 years or 15 years durability. So I would like to have this when a patient's at age of 66 instead starting from 65. So it's just pushing the procedure away to have more years of this valve. And not only that, the valve is getting better year. So I would go with the PCI before going for TAVI in a patient with coronary artery disease. In case of pre-existing coronary disease, but deferred. Okay. I think I answered this question. How about which type of TAVR valve are easiest for coronary angiogram? So there are two types of valves. This valve, if you see here, this valve. So in order to reach the coronaries, you got the catheter across the struts. So it's difficult. But in this valve, it's short. You see that? Short, it's above the frame, so it's easier. With the balloon expander, it's easier to engage coronaries. With the self-expandable valve, it's difficult to engage the coronaries. Any role for TAVI in AR? Yeah, there is. If it is, we used to say no, it's only aortic stenosis, but now we do it for aortic regurgitation. We do that, but we take in consideration the annulus, not too big annulus, because we have a limit. In the Edward, we cannot go beyond 29. In Evolute R, we cannot go more than 30 millimeters. There is an Indian company called MyVal. It can go higher than that, but you know we cannot use it in our patients. And Al Habib, we only approve the Evolute R and Edward valve. يا شباب معاي.
معك يا دكتور. دكتور آخر سؤال regarding the conduction problem post TAVI.
Yeah, this very important question. Very important.
Is it affected by the type of the valve? يعني
yes.
Self-expandable more than the other. And second thing is, how long after TAVI should I monitor for conduction problems?
In your exam, say 48 hours. For the sake of your exam. And there are groups of patients. There are 5 groups. They classify them in 5 groups. In our in more advanced level of structural, we divide them in 5 different groups to make that the patients need high risk of pacemaker or not. But the only thing, one thing I need you to know, the one thing I need you to know is pre-existing right bundle branch block is the strongest risk factor for complete heart block. The other thing you might need to know, after the TAVI, if a patient developed progressive is 250, tomorrow is 280, I will keep him more. Day after, 290, 300, no, I'll keep him more. يعني اشوف في prolongation of PR interval. احس انه he is going to complete heart block. This patient, I will keep him more. The other thing, if a patient developed branch block, we finished and block. It was not present before and now it's present. There are three things that you might do. Number one, you can put a pacemaker. خلاص شيل هم. And this is wrong. Patient might have symptoms, and 50% of them will not need pacemaker. So it's a waste of money, a waste of resources, and the patients may have pocket infection. It's not free of. So this do pacemaker if there is left bundle. Number two, which I usually do, is to observe, make prolonged monitoring. And number three, and this is can be done, easy to be done, but we don't do it because it's not cost effective in my hospital, is to do EP study. It's axis, they just measure the conduction, make sure the left bundle branch, is this patient has a prolonged conduction in the AV node or hit below the AV node, and if so, then the electrophysiologist will tell me. So for your exam, would say I'll consult EP. But block, Ibrahim, what should you do? Post pacemaker, what should you do? Say I will consult EP. This is the right answer. But the way to do it is three things: either pacemaker, or monitor, or AP study. This is a very common question, by the way. It's very common disease. It can happen 5 to 20%, and one of the before it reached up to 40%. That's a lot.
دكتور عويد
Some
يعطيك العافية. I need to ask if there is a paravalvular leak, what to do with this situation?
Inside the lab or outside the lab? If it is inside the lab, if it is mild, if it's trivial, I'll leave it. If it is mild, I'll do balloon dilatation. Balloon.
Let's say
post balloon.
Yes.
Balloon.
Let's say he have gone home and he came back with paravalvular leak and follow-up.
Yeah, if it is more than mild, so we need to close it. We need to by endovascular. So we do plug. But we have the thing that you need to know in your level. If a patient has paravalvular leak and it is moderate, فما بالك لو كان severe, it's dangerous. It's a killer. It's a mortality. We would not have moderate paravalvular leak or severe paravalvular leak. We should not. It's a mistake. And this is how we diagnose paravalvular leak. If it is mild, you can argue. If it is trivial, you can argue. But to be honest with you, in my opinion, we should not accept any paravalvular leak.
Should we involve surgery at this situation?
No, no. We can close it. A plug.
Okay.
plug هنا. نحط لنا plug هنا وسكر. تعرف ايش هو البلج؟
Yes, yes.
شباب بعد سؤال.
دكتور في سؤال بالشات بوكس من مشاري. What's the role of CNS protection device?
Sentinel. Sentinel is, I usually do it as long as there is approval. Study showed it does not reduce overall stroke, but it definitely reduce the large stroke. And this is what we are looking for, Ibrahim and Bshari. This is what we're looking for. We need to prevent a major stroke. Minor stroke, patient get it, then he recover, then he move on. Major stroke, yes, it is low, as you see it in the partner and TAVI, about 2.4% in surgery, in TAVI. So 0.8%, يعني أقل من 1%. So أقل من 1%. You do this sentinel 100 واحد، لا 1000 واحد بس عشان تنقذ 8. هل هذا cost effective؟ No. But what I do it for everyone if there is approval and if it is safe, because sometimes patients, they have different aortic arch anatomy that make it so difficult to put these baskets. فبالتالي when you do it you might cause a problem. There is a controversy. That's why when we do CT scan, we assess the possibility of putting this cerebral protection device. So to answer the question, in your exam, you would say it's not routine, and because it did not show a benefit for all patients, but it meant large disabling stroke. So, and one of my colleagues said, you either do it for all patients or you don't do it for all patients. يعني ما تعالج ناس وناس. If you believe in the benefit, you should do it for everyone. If you don't think so, you should. Patient high risk of having stroke like bicuspid aortic valve, very calcified, you need to balloon dilatation, تسوي بالون ومتوقع انك تسوي post balloon dilatation. So those patients are more prone to have embolization. يعني احنا بالعاده نحط الفالف ونطلع. لكن في بعض المرضى they have heavily calcified valve, so heavy calcified valve. فلما نحط الفالف يمكن الفالف strain. So we need to dilate مرة ومرتين وثلاثة. فكل بالون dilatation في stuff is going out. And this one can cause stroke. When to repeat echo post TAVI as first reading and follow up? Immediately. I do TAVI in the table. Immediately. لكن the formal echo report will be done in the morning. لكن echo should be done immediately after TAVI in the cath lab. What the role of the CNS قلناها, is transcutaneous spacing a standard of care? No, it's transvenous. Is transvenous spacing. We do that. The is not a joke, guys. It's disaster. تخرب كل شيء سوينا. Would like to show you one of the cases we have done. The last case 2 weeks ago. And there was a chunk of chunk which is سنتنا ياسر عيسى. Yeah, ما موجود. Yeah, بعيد عني لكن it's helpful to listen to know. I think we have done now hour already. I think there is no more question. Best of luck, guys, and نسأل الله العظيم رب العرش الكريم أن يسهل أموركم وينجحكم كلكم ويجعل ما سمعتموه هذا يرسخ في عقولكم ويجعلكم موفقين أينما تروحون.
يعطيك العافية دكتور، شكرا جزيلا، ما قصرت.